audience. So if you have a question, just raise your hand and interrupt, because then they'll get it in video. Fantastic. We'll be on TV. So I think we'll just go to the basics, because I don't know who's been to the conference before, what you've already talked about. Teresa did a phenomenal job. I only had a copy of her slides, and I don't know what she talked about because I was absent, so I apologize. But you know, my name is Dareen Siri. Again, I'm a physician. I see patients all day long. I also do clinical research. We have a full-time research center, so we do all sorts of crazy things. I apologize for the slides if you can't see them that well. Let's go over an outline first. You know, we'll talk about pandas, the etiology, maybe some pathogenesis, maybe some clinical features. We'll go really quick because we don't have a lot of time. Diagnostic criteria, maybe some new treatment things. Of course, as an immunologist, I see immunodeficiencies, and that's the primary reason we started taking care of PANDAS patients, and of course, prognostic features. As far as the introduction, you guys understand this is a neuropsychiatric disorder. It is an autoimmune basis, you know, initially triggered by infection. Of course, as you know, we used to call it PANDAS because of the association with streptococcus. However, pretty much any kind of infection now, whether it has molecular mimicry or not, can actually induce it. I think there's an autoimmune basis. So most of the time the infections are now gone, but then we still have autoimmune issues to deal with. And so, of course, you know, the original PANDAS being related to the beta hemolytic type of streptococcus. So this is different than all the other streptococcuses in the world. This is not streptococcus pneumonia. This is a different kind of streptococcus that causes, for example, glomerulonephritis or kidney disorders. So the different strains that are present. And this is typically the kind that you think of as causing strep throat, strep pharyngitis. And of course, there are, you know, neuropsychiatric features associated with it. OCD, typical. Tic disorders, typical. There's usually crossover. Some people may call it a version of Tourette's disorder with the tics. And of course, there can be some genetic predisposition, whether that's OCD, tics, or even immune problems in my case. This is kind of an unexplored area, and there's a lot of research to be done. And so we are finding, of course, there's a lot of immune issues that are going through families, autoimmune things. And, you know, autoimmune begets autoimmune. So, you know, as you know, if you have lupus or if you have rheumatoid arthritis or psoriasis, you know, there's a high chance or probability that your child will develop some kind of autoimmune disease in their lifetime. And so we're seeing a whole lot of that, which hasn't really been touched upon in some of the previous lectures, I believe. Going over streptococcus first, you know, it's group A beta hemolytic strep, which is abbreviated GABSA. GABSA pharyngitis, no. It's easier to say strep pharyngitis. And of course, the common classic symptoms that we think about in strep pharyngitis, I mean, I think there are very few of us who haven't had strep throat in this room. And if you haven't, you are darn lucky, and I want your immune system to help. So, you know, typically there's a high fever. We're usually talking about at least 101.5, 102, 103, sometimes higher. And then usually the throat hurts. And there's a minimum amount of respiratory or, you know, those kind of coryza symptoms, those cold symptoms. Usually there's not a lot of stuffiness. There's usually not a lot of runny nose or drippy nose. There's usually not a lot of cough. But in this day and age, with all these wonderful medications, allergy medications, asthma medications people take, the great thing, sometimes people come in with symptoms, and then people, you know, may mistake them for allergies and things like that. Because of this complex world where we have medications on board, and also the different strains, the way it presents, there can be a lot of confusing pictures now. So we've seen kids come in with asthma exacerbations. Actually, they had a strep throat. We have kids coming in where they just had a stuffy nose, they thought it was a cold, and you know, people were treating them for allergies, and they actually had strep throat as well. So there's a lot of different versions now. So sometimes it's hidden, it's secret, it's difficult to treat. And especially with the phobia of using and overusing antibiotics, whether it's an adult or kids. Many times, you know, you'll go to a prompt care and they will refuse, no matter how much you beg or cry, and you're like, I've been dying for 3 weeks, doctor, they will not give you an antibiotic. And so it's been to the detriment to some degree, and I think that's why we're seeing the rise of things like PANS and PANDAS, because there is a resistance. And, you know, we've shifted away from basically culturing and doing, you know, those kind of treatments where we actually identify the pathogen to empiric treatment. And then there was that, you know, pendulum swing, like, let's not give any antibiotics and then wait it out and see. And so I think we're starting to see the rise of these kind of complications. We've seen also, you know, kind of misunderstanding of the pathogens. You know, strep pharyngitis in particular, a very beastly organism, has to be treated with the appropriate antibiotics to clear it. And we see a lot of like Z-Paks being given out, you know. So Z-Paks, which will not kill strep pharyngitis, and then it lingers, and then it causes problems. And so, so there's a variety of reasons I think that we're seeing a lot more PANS, PANDAS in the community.
And as you know, these are common classic symptoms, but many kids may not have those symptoms, and 15 to 30% of all throat infections in these kids are actually strep throat. It's very common. We think of it a lot. The question is, can we translate that to actually treating it? And then, of course, there are a lot of kids who walk around carrying it. Asymptomatic kids. I mean, it's not just nurses in hospitals. So, kids carrying it all the time, and in families as well. And many children actually do have respiratory symptoms as well. There are those classic cold symptoms, and so it can be a confusing picture. And of course, we talk about the PAS, which is obsessive compulsive disorders being seen in 1 to 2% of children, and tic disorders being seen in 4% of children or so. So the hard part is that, how much of that actually was PANS PANDAS before? How much of that is natural development? There's a lot of lack of knowledge, frankly. We don't know whether any of these kids really started out having PANS PANDAS-like symptoms, or whether it's just a natural part of growth and development. And the mantra has been it's a natural part of growth and development, but some of the kids aren't. I can tell you an example of a kid. In fact, I was just relating it to somebody else. 2 lawyers. They've got a beautiful daughter. She's going through peanut immunotherapy in our office. She had a stuffy nose about a month ago. They didn't want to treat her with antibiotics. Then all of a sudden she started sniffing, and it was a sniff like a tick. She would go away when she slept. She did it constantly. She did it when she was playing video games. She did it when she was reading. And then we cultured her, and she grew out staph in her nose. We treated her with Augmentin because it was a community-acquired staph, because now we're using less antibiotics, and actually it's sensitive to penicillin. Her tick went away within 24 hours of starting the antibiotic. So it's one of those things where we don't, that could have been normal. I mean, she's all of 8 years old. I have 4 kids, 2 of whom have had ticks in their life. Me being a doctor, I love giving antibiotics. so didn't persist. but you just don't really know. And so this is like the real-time evolution of these problems. And then thank goodness she responded very well. So let's talk about etiology. It seems to be more prevalent in terms of presentation, males versus females. That's hard to say why, because there isn't necessarily a sex predisposition or gender predisposition. It could be due to habit. It could be, kids. For example, like boys have a lot more staph infections because they wrestle. Those kind of things. But things are changing, and there's not necessarily a good rationale for that. So that may shift at some point. We talked about some of the symptoms with OCD and tics going together. And of course, this is the target age, which is 2 to 3. People are recognizing it younger, but usually it's typically 3 before puberty, so up to 12. Is there a possibility that older kids and adults can have PANS PANDAS? It's possible. I think that because we don't know, we can't just be dogmatic about things. This is really a heavy, intense area of research, and there's a lot that needs to be known and understood. The problem is that it's not something we typically think of in older children or adults. Have I treated some that came in with classic type symptoms? Sure. Are they a little bit odder or rarer? Sure. And then part of it is that I think they are better at expressing their symptoms and getting treatment when they need it. Like, my throat really hurts, I can't eat, as opposed to maybe a 4-year-old. So that could be part of it. So we talk about the pathogenesis. Obviously there's host factors. There's host factors in terms of susceptibility. And my role as an immunologist, and I'll show you some very brief data, in a little bit, is that for us, it's basically about 2/3 of the kids are actually having an immune problem. And it's just like development, whether kids are slow to grow in terms of height and stature, whether they're slow to grow in terms of development otherwise. Your immune system also is slow to grow, it can be. It can be familial, it can be an insult that happens, it could be a sickness, and we find often as immunologists that this might be the reason that some of the kids get strep throat and there's no problems, and some of the kids get strep throat and they have issues, or other infections as such. And certainly there's some kind of obviously abnormal immune response, some overactive immune response, which is what autoimmunity is an abnormal overactive immune response to develop these problems. And so we'll talk about OCD and tics, and I think you guys are familiar with those types of symptoms. And so, this is a little bit late. In terms of the symptoms, obviously one can be present. Typically, one or more can be present, and it spans the realm of neurologic, psychiatric, immunological, and of course social. So we talk about OCD. We talk about severe anxiety, mood disorders. depression. We've had kids who've had auditory and visual hallucinations. They have impulsivity. They're considered defiant. There can be regression of motor skills. They talk about poor school performance, regression of handwriting. Those kind of things can occur. Personality changes. And of course, many, many of them, as Teresa talked about, with sleep problems, nightmares, bedtime rituals, those kind of things. A lot of rituals in things like bathrooms, rituals with cleaning, all those kind of classic things you think about with OCD. So in terms of timing, we talked about that 2 to 3 year time frame until up to 11 or 12 when puberty hits. Of course, if puberty is delayed, you might be able to see it a little older than that. Of course, so OCD and tics may be present in a child already. And it may be mild, and maybe the parents didn't think much of it, and then the kid gets a problem, an infection of some sort, and then it gets worse, and so now it's manifesting. So it also could be that these kids have it for the first time, like the little girl I just described, and of course it may resolve, especially with quick identification, quick treatment, or it may continue to be episodic. Especially, we see a child. Yes.
Question: have you seen with the onset of puberty, symptoms decrease for children with PANDAS or PANS?
So we largely have seen most of the kids in initiated treatment before puberty. So it's just like a lot of things, there's a developmental aspect, and a lot of times their immune system also gets better. So we give you till the age of 16 until your IgA is considered normal adult levels as well. So that's kind of a loaded question.
Yeah, that's why I asked.
Yes, yeah. Have I seen kids who are older than that have classic symptoms? Yes. Yeah. They're already fully formed, and they look like you and me, except they're 16.
Right.
Yeah.
Yes, I've heard both that symptoms can be exacerbated once puberty hits, or they can subside. So.
That's a very good question. As far as once puberty hits, symptoms getting worse, I have not personally seen that, but again, an area of research. It's really not known. Yeah.
Thank you.
I think there are a lot of other things that happen in puberty. Maybe things like defiance. That might be natural though, normal. And then we talk about it being episodic thereafter. Hopefully, with the first treatment, if it's identified early, treated, and then hopefully there's 100% recovery. Hopefully as time goes on, you'll see less and less of that. And they talk about a lot of times with treatment, and we tell patients that a lot. With treatment, the biggest thing might be time. We say tincture of time. We initiate the treatments, we hook them up with a therapy, and sometimes it's just waiting. Immune systems, as we follow it, a lot of them do get better. Not all of them, but a lot of them do. And then, of course, we talk about basically these immune-mediated behaviors. Again, with the hormone thing, things like menstruation, things like that. I haven't seen any of those specifically exacerbating PANDAS type symptoms, but when a child doesn't feel well, I think many of these things can manifest and feel worse. So it just depends on what's going on with them. Yes.
When we're talking about adults with PANS or PANDAS, could it be a non-treated child or a teenager who gets to adult as far as age, but then has flare-ups with other infections?
Yeah. We've definitely, that's been seen, where maybe a child initiated treatment, and back in the day when things weren't affordable, the parents couldn't afford any further treatments. Now the child has really severe symptoms, they're grown to an adult with severe symptoms, and they still can have exacerbations. Yeah, that's definitely possible. And so, we talked about diagnostic criteria. Of course, there's not a single blood test to say you have PANDAS. I wish there was. It would make life so much easier for everybody. But of course, it's a clinical diagnosis, and you still have to exclude all those other nasty potential things that it could be, such as cancer, and thyroid disease, and other forms of encephalitis that have rapid treatment. And so we talk about the presence of neuropsychiatric symptoms, usually pediatric onset, strep or other kind of infection that are similar. An episodic course, and then of course, and of course the sudden onset or abrupt onset, which is, like my child was perfectly normal yesterday, and then within the span of a day, a week, I have a completely different child, and this is not my child. And it is tough to tease out. I think there are many, many centers and many, many physicians and nurses and people who care for children with PANDAS who are getting saturated with other conditions. And I think that they just have to do their best to try to tease it out with the symptomatology that we know. And it's not that those other kids with different disorders can't have PANS PANDAS too, because they can. Those kids are susceptible as well. In fact, I feel like they're more susceptible because they already have something wrong with them. And so as far as, this is a little bit off here. I'm not really, oh, there we go. Oh, all I had to do was fix that. Let's see if it catches up. So as far as investigations, what can we do to diagnose it? We can do a throat swab, followed by culture. As you know, a test is just a test. It has to be confirmed by culture, or sometimes a rapid strep misses it. There can be blood tests that can rise in a matter of 10 days with IgG response. So child gets strep, within 10 days or so, 10 to 14 days, you can see actually strep titers rise. Usually not much sooner than that if this is their first time. And then, of course, we have to rule out other diseases. So usually there's a battery of tests that we run to make sure there are no other problems. And in my case, I usually always check the immune system. And so we check the humoral response, the cellular response. So humoral response being like the immune globulins, things like that. We check the cellular response being lymphocytes and those kind of things. And then, of course, the complement response, because we want to look for a reason that a child is susceptible. And so we typically include an immunological evaluation. And so, the simple blood tests, not hard to do. Okay, I think I'll just scroll this. So in terms of the humoral response, which is the most common deficit, the other two being not as common and usually they're redundant, are quantitative immunoglobulin levels. So we usually check IgG, IgA, IgM, and then we check their function. So even if the numbers look good, it may not mean that the antibodies that are present are functional. So typically we'll check for previous infections we know the child has had. And the easiest way is to look for vaccinations that the child has had. If they've had a Hib vaccine, then we check for titers. If they've had their series of Prevnar, we check for titers. Some of the kids truly, they weren't sick at the time when they got their Hib or their Prevnar when they're 1, 2, and then now we're checking them, they're 6, 7, and they don't have Hib titers. And they don't have pneumococcal titers, even though they should, especially with Prevnar, which is a really good vaccine. And so clearly there was something wrong during that process. They didn't develop their immune system correctly, and they were susceptible, and now we see a kid with PANS PANDAS. So this is unpublished data. I've been collecting them, and there's still patients missing because I did my very best to kind of try to remember all the patients we had. So I'll have to go back to the database. But out of the 35 patients that I looked at, this is our spectrum of patients. So 63% of them had an identifiable immune problem. And so we had, 69% of them had some kind of IgA problem. And again, we give you up to the age of 16 to develop a full adult level of IgA. So it could be a transient problem. Many of the kids, it is a transient problem. However, that doesn't mean they're not susceptible to issues. So as you know, IgA lines the sinuses, it lines the gut, it lines the urinary tract. It lines, the throat, the mucosa. That's what we call the interface antibody. It gets secreted into those areas. That's the first line of defense for those types of bacteria. And so unfortunately, when your IgA is a little lower, and it is the most common immune deficiency, it's 1 in 300 people, adults and children. And so because of that, that's a very common thing that we've seen. And then, of course, hypogammaglobulinemia, meaning that, that there was some low IgG at some point in the child. That was about 9%. And then IgG-SD is a specific antibody deficiency or subclass deficiency, one of those immune globulins, IgG, that was slightly low. And then common variable immune deficiency, which is a constellation of low IgM, low IgA, non-response to some of those vaccines, and then low IgG. So that's a host of kids that we see, 14%, which is way higher than the population of people with CVID in the universe. So a number of those kids having presented with PANS PANDAS in our clinic. And of course, manus-binding lectin, which is a complement pathway. We've seen those with severe defects as well. And typically we think of that as most important when you're children because you're still developing a humoral immune response. So those are, what we call primitive proteins that are developed in the body. They're made by the liver. They're floating around with all the other complement, manus-binding lectin complement, alternative complement pathway, and then they glom onto bacteria and then cause the immune system to, scream and shout and poke holes in bacteria. And unfortunately, for children who don't have a really developed humoral immune system, they rely on that. And so we think of manus-binding lectin deficiency as most important in the ages of, from about a year to basically about 5 years when they're still getting their vaccinations and, having their friends sneeze on them and those kind of things and developing that humoral response. Let's see. So still collecting those. We'll plan to publish those at some point. Okay. So as far as treatment, of course, the first order of treatment is treating the infection, the group A strep infection, typically with an antibiotic, and initiating as quickly as possible, as identifiable, and then therapy for OCD tics, immunomodulatory therapy if there's a lack of benefit or resistance, and then of course we talk about prophylactic therapy for long term. Oh, I'm sorry. You guys should just wave your hand and say, hey, there's nothing on the board. Let's just see. So I can go back a slide to see. Yes?
If you, and I do have a student that has this. Now they're talking about doing, if some, like even some psychiatric medications with this, or is it, because it hurts pretty severe.
Right.
You heard about that, or?
Yes, I'm sorry, yes. So the 4 pillars of treatment are treating the strep infection, treating the OCD tic disorder, immunomodulatory therapy, and then basically prophylactic therapy. So those are the 4 pillars. And so we'll pause for a second there, and then we'll scroll to the next slide. And so let's talk about therapy for the strep infection or whatever infection first. And so usually, there's a positive culture, there's a positive blood test or something like that. There's usually a rapid that's positive, and then we choose an anti-streptococcal therapy. And these will decrease the incidence of complications, hopefully decrease things like pustules in the tonsils and such, and then hopefully decrease the risk of transmission and decrease basically PANDAS continuing for the most part, and might even prove to have 100% resolution if treated quickly at appropriate doses. And so, in terms of the antibiotic choice, there's a recent study which showed that penicillin-based an average of 10 days to improvement, and cephalosporin-based an average of 5 days to improvement. Either way, treating it quickly is the most important, whichever you want to choose. And then of course we talk about things like decolonizing and sanitizing, decolonizing things like toothbrushes and fomites, things that people touch, towels, and of course their brother or sister who potentially may have given it to them should be identified, or the parent, especially healthcare workers, and to, check those family members, especially if the child keeps coming back with recurrent infection. And daycare is daycare. There's nothing you can do about that, unfortunately. So, and then of course, if medically appropriate, if the child's having enough strep throat, if they're having enlarged tonsils that are not being medically shrunk, or if they're having sleep disorder in the middle of the night, then an ENT referral may be medically appropriate to get the tonsils taken out. There's a mantra like, oh, you take tonsils out, it cures PANDAS. Well, it's not necessarily always medically appropriate to take the tonsils out just for one episode, for example. And we don't know if there's any long-term immunological issues from taking the tonsils out. So we like to say that, but typically it's the ENT's choice. It has to be medically necessary. So that's not something that we typically pressure the family to do. Okay.
As far as the next pillar, which is the therapy for OCD tic disorders, of course there's pharmacological and non-pharmacological treatment.
Do you recommend ibuprofen or histamine blockers for your patients? Because I know it's a swelling brain and the inflammation in the brain can be addressed through ibuprofen.
Sure. So as adjunctive treatments, I think it makes people feel more comfortable. Is there any proof that using things like non-steroidals actually truly takes away inflammation and cures the problem? No. But I think that it makes people feel more comfortable, and so it could be an adequate adjunctive treatment in the right patient. But then, of course, you get complications potentially, like stomach ulcers, etc. And so it's something to be judicious about. It's not every child that comes through our clinic automatically. And so I know that there are some centers where they have a protocol and everybody gets the same treatment. We don't really do that, but we're also not central receiving 10,000 patients. So we individualize this. Your other question was with histamine blockers. There's not specifically any indication right now that there's excess histamine being produced in any of the children. So is there a utility for things like Zyrtec or Benadryl or Claritin or any of those medications? Not specifically. And I personally haven't seen any kids who look like they have like a high histamine state, unless they have really bad allergies. So again, that's not something that we typically use as a routine basis. But certainly if the kid has a dust mite allergy and they're sneezing and they're allergic to peanuts and having symptoms, it's going to make them feel miserable, so they should be treated, and overall they'll feel better. So we talked about pharmacological versus non-pharmacological, and of course, we talked about some mental therapy, cognitive therapy, and of course motor therapy for those kids who have progression, have handwriting problems, need a little OT, those kind of things, and certainly that can be seen. So as far as non-pharmacological, we really would like a psychologist on board for these kids. Cognitive behavioral therapy is, I think, a buzzword, which seems to be effective and work well with kids. Family counseling, as I think Teresa talked about, because there's a lot of family issues, it becomes the sick child and only the sick child, and the rest of the family members seem to get ignored. I remember there was a kid who came in with PANDAS, and then there was a sibling sitting next to them who was like a teenager and coming along being supportive. And I was like, well, how are you doing in this? And then they went off. Yeah, they were like, yeah, everything's about this child, and we don't get to do anything fun, blah, blah, blah. And we're like, yeah, I think they just build their guts. So I think that's important to recognize that the other children are important and have needs too. And then of course, we talked about PT, OT, and pharmacological. We love psychiatrists to be on board as well because they can manage those medications like SSRIs, which are the foundation, and then to talk about the other medications that may be helpful otherwise besides SSRIs. And sometimes anxiety medications. And of course, school-based referrals, or the school is lucky enough to have nursing staff, counselors, those kind of things. And Teresa already talked about the accommodations and things like that. So for those kids who failed treatment, maybe they haven't been recognized, maybe they were recognized but they're not responding that well, they're still acutely ill, they have moderate to severe symptoms, it's burdening their life, we're talking about like pulling them away from school, they can't function anymore, the parents are going crazy because they have to stand in the bathroom for 10 hours a day, those kind of things. So then for those kids, then we talk about advanced treatment, which could be something immunomodulatory, which could be systemic steroids, hopefully not repeatedly because it's just bad for you. We talk about things like immunoglobulin therapy, which has a variety of functions, especially in our kids with immunodeficiencies, but also to saturate receptors, and that helps with many autoimmune diseases. Plasmapheresis with that same concept of autoimmune disease, filtering out those antibodies. And then, of course, the line of immunosuppressant treatments like rituximab, which some centers do. And rituximab, if you're not familiar, is a medication which pretty much kills the B cells, which produce IgG or antibodies. It's used in a variety of autoimmune diseases, etc. Quickly we'll just profile like 3 different things. And so with IVIG, there was a randomized controlled trial for IVIG for PANDAS, and really the patient-reported outcomes, or what we call the PROs, was greater in the IVIG group than the placebo group in the study. It was a small study, not that many patients, because as you know, it's hard to conduct a randomized clinical trial in kids, and nobody wants to go on placebo. So luckily for these kids, there was a small study, less than 15 kids. They had an open label arm as well. It's always really difficult, because when you get good care, you're a center, everybody has a placebo effect, and they're going to be asked questionnaires, they're filling out diaries, things like that. So I think it was a difficult study to do with a very small amount of kids. But in any case, when they looked at it overall, there seemed to be more improvement of those patient-reported outcomes in the kids who had treatment with IVIG, but it wasn't statistically significant, and the between group differences in that study was smaller than anticipated. So the use of IVIG in another study was a case series, and it was a local doctor here, Dr. K, who you guys might know. He did the case series describing 12 youths treated with IVIG, and really their patient-reported outcomes, things like that, were all very favorable. But again, case reports being a large majority of what drives the data in PANDAS, because again, it has been hard to do randomized clinical trials. But they're ongoing, and as you can see, some of the doctors have put out that poster, again with patient-reported outcomes, showing a trend generally that those kids receiving IVIG are having improvement cognitively. But again, you still have to deal with that center effect when you go into a clinical trial and they get really good treatment and everybody's staring at them and saying, how are you feeling? So, always difficult. So plasmapheresis, there's really not a lot of literature out there. There are kids getting plasmapheresis. And plasmapheresis being, where you filter the blood and take out the antibodies. This was a case of a child who was originally diagnosed with schizophrenia, severe anxiety, etc. And then they filled to the criteria of PANDAS, and they were given basically the plasmapheresis and had marked immune improvement. And we've heard of some patients improving. I personally do not write for plasmapheresis, so I don't have any personal experience with this. We've heard of some patients getting it, and finding that it was beneficial. So plasmapheresis and IVIG, you know, kind of along the lines of immune diseases or autoimmune diseases are probably equivalent, you know, in our case. As an immunologist, we write for a lot of IVIG, and so that's the only reason I write for it. But if, you know, I stood next to hematologists and they were like, plasmapheresis is the way to go, I wouldn't necessarily argue with them. And then rituximab, which is kind of the new kid on the block, has been used for a long, long time. And there's another medication that's very similar, it's a B-cell suppressor. It's been used for a long, long time in adult autoimmune diseases and other autoimmune diseases. And so this, as you know, kills the B cells, you know, and then basically you don't make IgG, which are, you know, the foundation of, you know, your immune system to protect you, but also autoimmune diseases, which are being overproduced. And so in this case, this was a study that was put forth in 2014. None of these kids, however, had PANS or PANDAS, but they did have a variety of other autoimmune and inflammatory central nervous system diseases. There was a total of 144 children of all different types. They had to have at least 6 months of diseases in order to get into the treatment, and they were severe. They reached their very end, which is why, you know, we're talking about killing B cells in kids. And so overall, you know, in 55% kids were given, you know, those patient-reported outcomes and disability score improved. And overall, 87% of the patients found improvement. So the change was definitely greater and more effective earlier in the course of their disease. So if they've had it for multiple years, it was definitely less effective. And that's PANDAS overall, PANDAS overall. The longer the kid has had it without having an intervention or treatment, the longer it takes to identify, the less, you know, potential 100% you get back. And we've seen that a number of times. And sometimes, yeah, the kids are now teenagers and they weren't identified, they didn't get treatment, and we really, there's not much I can offer them. And so that, you know, other than, you know, what you guys can offer them as psychiatrists, psychologists, and this but from a medical perspective and, you know, just like medication, antibiotics, it's hard for us to kind of offer something. And so in this case with the rituximab, you know, it's limited because of the side effects of rituximab. I mean, there's up to 8% risk of serious infections. You know, infections including opportunistic infections that cause things like, you know, progressive multifocal leukoencephalopathy, JC virus, and those kind of bad viruses that usually don't cause disease. And also neutropenia, anemia, long-term decrease in IgG, meaning you actually have induced immunodeficiency now in those kids. So, you know, for the kids who are no longer responding to plasmapheresis IVIG, I think this is an option. And there are only a few centers that do this, of course, because of the higher risk of potential problems. And so once we get past, you know, kind of this stage, and maybe the child hasn't been doing well, and then we talk about prophylactic therapy. You know, you had a kid, they had PANDAS, they're doing relatively well, they're 90 to 100% better. What do we do at this point? Do we just leave them alone and say sayonara?
Can I ask a quick question?
Yes.
That IVIG therapy, I have a student that's just starting that. How can you explain that to other school personnel in layman's terms, what that is?
Okay, so they're getting basically a blood product.
Okay.
That is when you talk about the blood, there's the red cells, the white cells, and the clear stuff. So it's the clear stuff. The clear stuff with all the good proteins.
Okay.
And so they're getting that to basically treat them to improve their immune system, you could say, so
Okay.
that they can handle their disease better.
Beautiful, thank you.
And it's a blood product, it's a transfusion essentially. We call them infusions, but it's really a transfusion.
Transfusion, okay.
How
Thank you.
many IVIG or plasmapheresis treatments can a student get?
It depends on the problem. So if they have an immune deficiency, like they were born like Bubble Boy, like John Travolta Bubble Boy, they get it forever. If they have PANDAS, you know, typically most doctors will try 3 to 6 and then see where we're at. And then usually most of the kids are better by then and they don't need any more, but not every kid.
And does the insurance cover 3 to 6 with this law?
That's,
It should, but it's still a problem.
I'm not a legal expert. I know that it's supposed to cover IVIG. As far as the number, I don't think that's codified.
They have created a policy in order to limit the number of IVIG that a child can get.
I mean the insurance companies.
The insurance
Yeah,
companies now.
not the law.
So the insurance companies now, Blue Cross Blue Shield specifically says 1 IVIG. But the law trumps that policy. So if you have families coming back to you that say, you know, we can only get 1, we can, you know, and if the doctor says the child needs more, you know, we feel the child needs more, the law should trump that policy. So they need to go back and begin talking to their insurers.
And that's super expensive, I take it.
It is very expensive, yeah.
So then we need to guide the parents to.
Please guide the parent to go back to their insurance companies,
Go back to the doctors.
and their doctors to talk, but because really, the parent does not decide how many IVIG this child needs to get. The doctor needs to decide that issue. And then, you know, but do help guide those parents in going back, what's the word that I want to use? Not confrontationally. Advocating calmly, understanding the science and their needs, being able to work well with the doctor. I mean, these things are just paramount in actually getting their needs met. And oftentimes what I see and what I end up coaching parents through is like, step back, you know, breathe, and let's talk to those insurers, you know, calmly and see what we can get. It's the same thing. You know, if you're a school professional, you see this every single day. So it's the same concept. You need to.
So just to comment on that before we take this question is that, you know, so oftentimes what happens, you know, we know that insurance companies have to have checks and balances because, you know, otherwise then everybody and their brother would use up the IVIG in the world. There's only one that supplies for everything, from town now. And so, you know, it's reasonable to say, hey, you know, can we try one and then ask for medical necessity? I think that's reasonable. What frustrates me is that then there's medical necessity and then I don't get it from some insurance company or other. But, you know, I think it's reasonable to say that. However, the problem is that for many families, they're busy, they're living their lives, they're trying to survive and, you know, tread water. So what happens is they get their IVIG treatment, the kid does well, and then they come back 3 months later. And then, you know what, I can't establish that you actually need any more therapy because you never came back to see me. So if you, as, you know, if any of your school nurses or psychologists, things like that, please encourage them, you know, as soon as you get any kind of intervention or treatment, especially expensive therapy that we work really hard, hours and hours to get for you, you must follow up to demonstrate whether you've improved or not. Because maybe you didn't follow up because it didn't work. But, you know, I can't go back in time and, you know, write a letter saying, yeah, well, mom said 3 months ago that she thinks that the kid was better. So, yeah, or like, you know, oh, I have to write a note for 3 months ago because now the child has been taken out of school because it didn't work. I was like, I can't go back in time and do that. It's really hard for us morally to do that. And so we do encourage them to follow up, and that's the hardest part that we have. You had a question?
What time span the IVIG is given?
It depends on the protocol, but, you know, some people give it 2 weeks apart, some people give it a month apart, but it's usually in succession. Yeah, we usually give it in rapid succession because we want to suppress all those receptors very quickly, just like if you were treating a lupus patient or Behçet's disease or any of those other bad diseases. With that, yes.
Would you say IVIG is more appropriate for more severe symptoms? Or if there's a child where the symptoms, it's anxiety, not school refusal, not, you know, eating disorder or anything like that, if it's more of a mild case, is IVIG too much? Or would you stick with an antibiotic protocol, or is IVIG for everybody with PANDAS?
I think that, no, it's not for everybody. The hard part, again, with families is that, you know, everybody wants to take a pill and make them better.
Absolutely.
But you have to put work into therapy.
Yes.
Work. And so we see a number of kids where the families don't have a therapist or a psychiatrist. And to me, this is one of the pillars of treatment. You have to have that. And so we refer them. And if they don't have one, and they don't like one, and they have to drive 3 hours to get one, you know, they have to have that because the child will never fully heal without, you know, those, unless maybe the 2 parents are psychologists. That would be great. But you know, so we often say, you know, things like, you know, I can't say that a kid who has anxiety alone doesn't qualify because maybe it's so severe that, you know, it's impacting their life that they can't function. So one symptom alone may be severe enough. So it really has to, we have to look at the whole picture as far as quality of life, the impact, the disease, things like that. And if they've tried like five SSRI, and now the kid's addicted to benzos, you know, I mean, this is inappropriate, right? So I think that, you know, we have to be judicious with any kind of expensive, hard to get treatment, but at the same time it may be appropriate.
One more question, sorry. What was the time span between actual infection and symptoms?
It's typically very rapid, yeah. It's typically like within 2 weeks. Yeah, within 2 weeks.
So it could be just at almost like a few hours after you start to have an stress infection.
It could happen within hours as well. But most of the time, it's hard to say because people could be lingering with symptoms, or they could be holding it for a while before they manifest. But I haven't really seen any cases where we thought it was convincing PANDAS where the child had a strep throat and then 3 months later they had symptoms. I think that in those cases, maybe they weren't fully treated and they were holding on to something or something like that. So there's all sorts of options there.
And what other infections have you seen?
So that's a very good question, and that's a little bit of a controversial topic. I mean, obviously, any of the humoral type of bacteria we've seen. So I've also seen PANS-like things after things like influenza, so viruses as well. And so the question is, how does that work? Because we think that, especially with strep, we think it's your body, not understanding the child's body not understanding how to process those antigens, and so you recognize it as self, and then you attack yourself. So that's what we call molecular mimicry. But it can happen with many things. And so this is the basis of many autoimmune diseases. We think that's why people get lupus. We think that's why people get a lot of autoimmune diseases, is that your body has a certain way of processing and splicing your genetic material when it's trying to figure out how to attack something, and it's doing it in a way where you deficiently lack self-recognition and self-tolerance, and then now you're immune to yourself, or you're having immunity to yourself. That's the basis for thyroid disease, type 1 diabetes, all sorts of things. And we know that this is happening more and more in our society.
I have a lot of students with public aid, so does public aid cover IVIG?
Public aid, I believe, covers IVIG as well, yeah, as long as it's medically necessary.
Can you just explain the importance of hydration to the school nurses that are here, and so that they can report it back to the educators before hydration before IVIG and after IVIG?
Okay. So how does that relate to the educators? Can you help me out? I'm not an educator.
The importance of the child having hydration before IVIG, so if the parents are requesting more water, they understand the reason why they're requesting more water.
Got it, yeah. Okay, I was thinking in the case where, so many of our kids basically get IVIG and they took it fully off of school, but for kids who basically, maybe they don't do that, because they're routine. Yeah, hydration helps anything. I mean, it really just helps anything. So when they get infusions, things like that, I mean, some of the IVIG products have been rarely, hopefully none of them anymore, but have been rarely known to cause things like kidney damage as well, as a super rare side effect. I don't know how much of that is true. It depends on the sugar residues, things like that, that are processed in the IgG product. But anytime you basically have hydration, it helps turn the system through, hopefully prevent things like kidney damage, those kind of things. So yeah. So and then also side effects, headaches, those kind of things. We're not getting the slides back, but in any case, so my next topic was prophylactic therapy. So prophylactic therapy and prophylactic antibiotics to prevent recurrences is not in the guidelines. A lot of kids come in and they're on high doses of antibiotics for years and years and years. That is not specifically written in the guidelines. So if your practitioner, your physician, whoever's taking care of the kids believes in that, again, it's an area that needs to be studied. So I'm not going to be the one up here on any kind of podium saying it's wrong or right. It's just not in the guidelines. And so if the parents really believe that they need it, fine. I typically, as an immunologist, don't do that type of treatment because we don't typically prescribe the antibiotics. We prescribe the immune treatments afterwards. So we typically see the more severe kids anyway. But you may see that a lot. Kids on antibiotics long term, multiple antibiotics, etc. So the question is, preventing the recurrence of a problem. Like, let's just say the child is treated, they've been treated with the correct antibiotic, and now you have a normal child. And the question is, what about future infections? Are we going to give them an antibiotic long term to prevent all these potential problems? And so they did a study. So using prophylactic long term antibiotics will prevent 0.06 per year, 0.06 exacerbations per year. So it's kind of a tough call. But that's an older study, so we'll have to see. And then again, people talk about gut bacteria, gut health, those kind of things. Those things are important. Long-term antibiotics, things like that. It does cause a lot of issues with malabsorption, digestion issues. But again, if your child is immunodeficient, we use prophylactic antibiotic therapies a lot. And as I said, in our case, 2/3 of them are, the kids that we see. And so we use a lot of prophylactic antibiotics because we don't want the kids getting sick. for any reason, because they may get pneumonia, they get chronic sinusitis, and may have a bad outcome. So, I think that before it hasn't really been talked about because we don't know what those kids' immune systems look like. So, it still needs to be studied. And then, so what about prophylaxis with immune globulin? And again, if they have immune deficiency and they still have it, we will offer it because they truly have something that is an immune problem. However, not all families will choose to go on it because maybe it's mild, maybe they feel it's manageable, maybe their kids are homeschooled, maybe they believe in sinus rinses and do a lot of hand sanitizer and stay indoors and pull their kids out of school when it's flu season. So it's whatever's compatible with the parent's lifestyle. There's some kids, I saw one this week who really has a very severe immune system, and he has common variable. His IgG level is like 300. But you know what? He's largely doing very well. So we're not going to treat him or offer him IVIG until the parents feel like there's a problem or he has an infection. So you have to have infection, plus you have to have an immune system that doesn't work. So it has to be compatible with, again, with the parents' beliefs and things like that. And so, as far as continuous treatment, then if the patients do want to have it because they're afraid for the future, they want to prevent pneumonias, those kind of things, they've had multiple pneumonias, etc. Of course, we'll offer it, and that can be either given under the skin or IV. It doesn't have to be IV. And then we do periodic assessment of the immune status to look at them to see if they're growing out of it or not, because they may. And that's the exciting part, is that a lot of them do. Their immune system's beefing up, and then they're good now. They're 16, 17, etc. And then, of course, the goal in that case with these, with IVIG or sub-QIG is to basically prevent deep-seated infections, not complications. Not specifically just to prevent like a sinus infection. And so as far as prognosis, again, prompt recognition, which leads to prompt treatment, which then begets prompt and potentially 100% or full resolution, which we've seen many times. But again, it takes an awesome pediatrician or family practice doctor or prompt care doctor to recognize that, or a school nurse to recognize that, or a psychologist to recognize that and say, hey, go get treated. So we've heard those stories too, which is great. And then I think we kind of talked about those. Okay. And oh, that was the end of my talk. Because she gave me the 5-minute wave saying, you gotta stop now. Any other questions?
So what was the prognosis?
Okay, I can scroll back. I'm sorry. Yes. So yeah, the longer it goes untreated, the worse the potential prognosis is. You may not get that 100% back. And this is the frightening part. So the hard part for us is that if we recognize that a child gets antibiotics, gets treated quickly, and then is doing great, that's the best scenario. We've seen a number of those cases. However, let's just say there's a delay, and then the child gets antibiotics for some improvement. Maybe the child gets a little bit of steroid for some improvement, and then they go on IVIG, and then the longer we have to wait for that IVIG to improve is the real detriment to the child, because at this point, they're already out of school, they're already suffering, the family's suffering, and then now we have to wait for pre-authorization. That kills us.
How long does it take for pre-authorization?
It can take anywhere from, it depends on the insurance company, expedited route, how convincing I am. It can take anywhere from a week. Thank you, Confusion, for helping us. We sometimes ask especially pharmacists to help us, and everybody we know to write letters and help us, including sometimes nurses and psychologists, to even several months. Yeah, because they want more letters, they want medical custody, etc. So yeah, the more the families basically record and follow up, keep track, and have done all those other things. So she's the one who does all the honors for me. Thank you. And so yeah, it can take a long time. Wouldn't you say? How long? How long did you wait for treatment for a child?
Oh, it ranges, you're right. I would say a month to 3 months.
How much is it out of pocket?
It depends on the dose. But let's just say 40-kilogram kid, maybe getting 40 grams, about $4,000, one treatment. So this is pooled from 5,000 to 10,000 donors. This is a limited supply. The United States basically supplies the whole world, except for like China and a few countries. Yeah, because we are the only country that pays our donors for plasma. One of the few countries that pays our donors for plasma. Every other country it's by donation only. And so there's a huge demand in many parts of the world, mostly for neurological diseases, just like this. So 90% of the IVIG that gets used is for neurological diseases, not for bulk boys.
So if the word got out, would people be willing to give if they knew that this was helping people? That,
Well, when the economy's doing well, people don't go and donate. So this, it's very impactful. Yeah.
So do you think that if I'm writing a review about this for general pediatricians, do you think?
Thank you.
And I'm the editor of a journal, I'm Joe Hagan, the editor of a journal called Pediatric Annals, and I'm just thinking about this and what the little that I knew about this. An immunology consult is part of what should be done.
Yeah, I think that traditionally it has been infectious disease, pediatric infectious disease,
Yeah.
sometimes pediatric rheumatology, and of course pediatric neurology. But a lot of immunologists do treat. I can't say the majority of them do, but a lot of them do. And especially as we know more and more of their immune problems, more and more
Yeah.
and more understanding that they need to be involved. Yeah. So we were involved in fellowship treating these kids, which
Yeah,
is why
yeah.
I know about it.
Yeah.
But many of the immunology programs, at least in this part of the Midwest, have not been involved, so they don't
Yeah.
treat the kids. Unless there's immunodeficiency, that's right.
Right, yeah.
Yeah, I just was, graced by going to a center where there was a PANDAS center.
Sure.
So, yeah.
What if a kid is diagnosed and treated with all of the above therapies and they don't improve?
Then they gotta go to Stanford. I'm just kidding.
Stanford.
So they've tried all these things, rituximab, everything.
Yeah.
Yeah, and so you're talking about a kid who maybe has been acute onset. They've come in like 3-6 months, they've been diagnosed, and they've gone through the gamut. Frankly, that's a hard one. I don't think I've seen a kid like that. So most of the kids who are resistant to treatment, it's because they had underlying issues. They had underlying issues before coming in. They had autism, and the parents are looking for an outcome that's not there.
Right, exactly.
Those kind of things, yeah.
You do see a little bit of that, and it's
Yeah.
sad because
Yeah.
they don't want their kid to have a mental illness, but some of them do.
Or we see a teenager now, and these discussions are being made for some of these treatments. They're not necessarily appropriate now because there's not an opportunity to change it, number one, or the only thing that is underlying now is anxiety. And so I don't, again, kind of like her question, if they have mild anxiety that could be easily treated with therapy and some medication, do they need IVIGs?
And then who do you get involved, psychiatrist?
Psychiatrists should be involved from the beginning. Psychiatrists, psychologists, therapists, neurologists if possible, maybe sleep, maybe sleep neurologist, depends on who does neurology, ENT maybe, immunologist probably, and of course infectious disease if needed. So, but usually, strep to strep, but it could be other unusual things like it could be weird viruses or something like that.
If the infection is treated, because I have a little girl, and like all last summer, her mom said she was having psychiatric issues, severe. And so once it's treated, do the psychiatric issues continue or do they stop? And you know what I mean? How is it the infection causing the psychiatric issues?
So
Or-
I kind of talk about it like PTSD.
Okay.
Like, you went through this and then, your child is like, has been affected by this and they have all these memories now, wetting their bed and doing bad things in the bathroom and, not being able to control themselves and feeling helpless. And so I think that psychiatry component has to continue beyond the medical stuff.
Okay.
Because they do, a lot of them have PTSD and they're anxious and they, they're like, well, I was feeling weird, now I go to school and this is the same. It's kind of like a smoker who goes to the same, like, bar. I mean, it's like haunting. Not that I've ever been a smoker, but I'm imagining. So wouldn't you agree? Yeah. And so, one of the most important things basically in treating the kids is to have a champion. Thank you. To have a champion that will basically organize all this stuff and send those referrals out. And so this is the most challenging part from the medical aspect is, who's going to be the
Dr.
champion.
Siri, Dr. Siri, what about the antibody levels and how long they stick around? So
Oh, yeah.
could that be the case in her example, that the antibodies are just sticking around and wreaking havoc and causing more inflammation?
So, we like to think that, the higher the antibodies, the worse it is, and that, if they regress and they kind of shrink and go away, that things are getting better. We like to think that. Just like we like to think, well, if you have a high IgE to peanut, then you're more allergic. It's just not simply the case. Some kids, they have antibodies that persist for a long time and they're fine. And some kids have antibodies that go away quickly with treatment. And we don't necessarily think those are the kids who are basically getting, re-triggered by, infections. So antibodies it's very difficult to necessarily correlate with that. And they've tried in some of the studies, and there's a trend, but there's not an absolute 100%. And it depends on the lab too. So the NIH or the NIMH, whatever, feels that any levels over 400 are bad. But most labs will report levels over 2 or 250 being abnormal. So anti-streptolysin O,
Got it.
anti-DNase B.
Okay. And so not so much, you can't really use that if you think that influenza or some other infection is
Yeah, you think it's some other, then of course there's antibodies you can get for pretty much anything, unless you're on FHA, of course. But yeah, so if you think it was, HHV6, or if you think it was triggered by Coxsackie, of course those antibodies could be followed as well. I think, some people check for mycoplasma, some people are checking for Lyme, those kind of things. So of course you can follow those titers. And again, it's hard to say if you see the titers go down, can you correlate it 100% with symptoms? Not necessarily. Yeah, kind of like the ACE level in sarcoidosis. Just because it goes up doesn't mean you're having infestation. Yeah. I think I'm done.